Good evening, everyone. I'm Dr. Mariya, Chief of Breast Medical Oncology at Yale Cancer Center. And we're so happy that you're here with us tonight for our one of two series on updates from San Antonio Breast this year. I have the pleasure of introducing my colleague, Dr. Mariya Rozenblit, who is an assistant professor in medical oncology and one of our key breast specialists within our program. She will present today early stage breast cancer, and then next week we'll have Dr. Adriana Khan presenting on metastatic breast cancer updates. A video of this session will be available in the Smilo YouTube channel shortly after the session, so you can refer to that for the archival content. As you think of questions, feel free to put them in the Q&A function of the chat. We'll try to get to as many of the questions live, and then anything we can't get to, we can provide some written comments for you. So with this, I will turn it over to Dr. Rozenblit. Thank you so much.
Thank you so much, and thank you to everyone for joining tonight. So I could not include everything from San Antonio, so these are just a couple of the trials that I thought were interesting, and hopefully you'll find this useful. I don't have any disclosures. So I'm going to be reviewing TAILOR-X subset analysis for the hormone-positive group, TBCRC 056 trial, Solti-Valentine, and for the triple-negative, we're going to be talking about neoadjuvant and adjuvant immunotherapy. And for HER2, we're going to be talking about the NeoHIP Margo Train 3, and a very interesting trial out of Europe, as well as the ZEST trial and the Olympia update for BRCA patients and the BeWell trial. So for the hormone-positive group, this was a post-hoc analysis that was presented from the TAILOR-X trial, looking at the impact of anthracyclines in high genomic risk node-negative hormone-positive breast cancers. And just as a reminder of the TAILOR-X trial, this was a trial looking at node-negative hormone-positive tumors that were T1C to T2 or high-risk T1B. And the recurrence score for oncotype was analyzed. Mid-range patients with a recurrence score of 11 to 25 were randomized either to endocrine therapy or endocrine therapy and chemotherapy. And everyone who had a recurrence score of 26 or above received chemotherapy and endocrine therapy. So this was a subset analysis looking at those patients that did receive chemotherapy and comparing patients who received ACT versus TC. And as expected, what they saw was that the patients who received ACT on the trial tended to be a little bit younger. A little bit more of them were premenopausal in the ACT group. The tumor size on average was a little bit bigger in the ACT group. And in general, patients who had a recurrence score on the higher end were more likely to be in the ACT group compared to the TC group. And most of the patients did receive dose-dense ACT compared to standard ACT. So when they looked at the primary survival outcome, which was distant recurrence-free interval at 5 years, they did see an improvement in those patients who had a recurrence score greater than 31 with ACT. So the 5-year distant recurrence-free interval was 96% in the ACT group versus 91% in the TC group. And they did not see this difference in recurrence scores below 31. They also looked at distant recurrence-free survival, and there was a difference as well, 95.4% in the ACT group versus 89.8% in the TC group. There was a trend towards improved overall survival, but it was not statistically significant. And when they compared by menopausal status, they saw a benefit in both groups, but it was more pronounced in the premenopausal group, with the 5-year distant recurrence-free interval being 96.9% in the ACT group versus 84.4% in the TC group in the premenopausal women. And overall, when they did the subgroup analysis, it seemed that the greatest benefit was seen in the premenopausal women, tumors that were greater than 2 centimeters. And so Of course, this is a post hoc analysis, so it's hard to make a definitive conclusion for this, but interesting to think about in our node negative premenopausal women with perhaps larger tumor size when thinking about which chemotherapy regimen you would pick for the, especially if the recurrence score is above 31. Another interesting trial that was presented was TBCRC056, and this is a trial looking at neoadjuvant niraparib, which is a PARP inhibitor, combined with immunotherapy, dostarlimab, for patients who have BRCA mutated or PALB2 mutated breast cancer. So this trial has several arms, but the analysis that they presented was specifically focused on their third arm, which is the hormone positive arm. And this included 18 patients. And so they received niraparib and dostarlimab for 18 weeks neoadjuvantly, and then were assessed after surgery. And so their primary outcome for this arm was PCR. And what they saw was that 3 patients did have PCR with this neoadjuvant regimen. And overall, when we look at the residual cancer burden of either 0 or 1, that was seen in 44% of patients. So that's pretty impressive in a hormone positive group where we see, in general, very low PCR rates. And overall, it was well tolerated. The adverse events were what we would predict with an immunotherapy combination. The most common ones were rash, increase in ALT, as well as some nausea. One of the main things that they were also investigating in this trial was looking at tumor-infiltrating lymphocytes. And they did see that compared to prior to treatment, after receiving 2 cycles of treatment, they did see an increase in tumor-infiltrating lymphocytes in the tumor, and that this was associated with a higher PCR rate. And so higher TILs at baseline were associated with an improved outcome, but also the increase in TILs with treatment was also associated with a higher likelihood of having a pathologic complete response at surgery. And so they're doing additional biomarkers to look at this further as well. So this was a small trial, but very interesting to think about PARP inhibitors in combination with immunotherapy in patients who have these targetable mutations like BRCA and PALB2. Solti-Valentine was a trial that looked at HER3-DXd in the neoadjuvant setting. So this was looking at hormone-positive breast cancers with a Ki-67 of greater than 20% or other high-risk genomic features, such as a high oncotype or a high mammoprint, that would make you think about doing neoadjuvant therapy in these patients. And so they received either HER3-DX by itself for 6 cycles, HER3-DX plus letrozole for 6 cycles, or standard multi-agent chemotherapy that you would give to in the neoadjuvant setting. And then their primary outcome was to look at PCR rates. And what this showed was, as expected, PCR rates were low, as we would expect in the hormone-positive population. But what was interesting was when they looked at the toxicities, HER3-DX and the combination of HER3-DX and letrozole actually had much fewer treatment reductions compared to chemotherapy, much fewer treatment interruptions, and much less treatment discontinuation. So overall, the PCR rates were equivalent, but much less toxicity with this combination compared to standard chemotherapy. And they did not see any cases of interstitial lung disease, which we often worry about with these antibody drug conjugates. So in the triple negative group, CAM-RELIEF was one of the trials presented looking at the combination of immunotherapy with chemotherapy in the neoadjuvant setting. CAM-RELIEF looked specifically at carboplatin nab-paclitaxel with camrelizumab, as well as anthracyclines in the neoadjuvant setting. And it did meet its primary endpoint, where the combination did show an improvement in PCR rates compared to standard neoadjuvant chemotherapy. And it improved PCR rates from 44.7 to 56.8%. This was interesting because a very similar trial with atezo, which is the NSABP 59 trial, failed to meet its primary endpoint. And so it's a little bit unclear why we are seeing benefit with the Keynote 5-2 regimen with pembrolizumab. We are seeing an improvement in PCR rates, and we have to wait for follow-up data to see if there's going to be an improvement in event-free survival with camrelizumab as well. And how come we're not seeing this with atezolizumab? So we don't quite know the answer. There was a very interesting comparison analysis presented at the conference, which looked at the stage of the tumors included across these different trials. And what this shows is that Keynote 5-2, which is positive and is the current standard of care with pembro, and CamRelief, which showed an improvement in PCR rates, had a higher percentage of the larger tumors included, like T3 and T4. So perhaps it is these larger tumors that are benefiting the most from addition of immunotherapy to chemotherapy in the neoadjuvant setting, as well as our lymph node positive tumors. And another analysis that was presented at San Antonio as well was the effect of exposure to chemotherapy. So perhaps it's not just the immunotherapy, but how much of the chemotherapy the patients were able to tolerate, that's also important. And so what this is showing is that patients who received what they defined as full chemotherapy exposure, meaning 10 to 12 doses of paclitaxel and carboplatin, as well as 4 doses of the anthracyclines, were much more likely to achieve PCR when they had that full chemotherapy exposure in addition to immunotherapy. So also something to think about when we're comparing these different trials, to look back and see how much of the chemotherapy were the patients able to receive. A-BRAVE was a study looking at adjuvant immunotherapy, and this was looking at patients with triple-negative breast cancer who were randomized, who had residual disease after their neoadjuvant treatment, and they were randomized to avelumab versus observation. The co-primary endpoints were disease-free survival in all patients and in the post-neoadjuvant patients. And their primary endpoint, there was no statistically significant difference. However, what was interesting and what they presented at San Antonio was they went back to look at a subset analysis of patients who did seem to derive benefit. And what they saw was that higher RCB, so higher residual cancer burden, was predictive of more benefit from avelumab. And it's showing disease-free survival as well as overall survival. Overall survival was not significant, but disease-free survival seemed to be trending towards significant benefit in the RCB3 group. And they also looked at those tumor-infiltrating lymphocytes, and what they saw was that patients who had fewer TILs, so less than 10% in the residual disease after neoadjuvant therapy, seem to gain benefit from the adjuvant immunotherapy. So perhaps there is something about adjuvant immunotherapy that is perhaps boosting the immune response in these tumors that don't have a lot of tumor-infiltrating lymphocytes in the tumor, especially after neoadjuvant treatment. But of course, this is a subset analysis, and we need to confirm this in larger trials with more biomarker analysis. In the HER2-positive group, NeoHIP was a very interesting trial looking at HER2-positive breast cancers greater than 2 centimeters with or without positive lymph nodes, randomizing to THP, THP plus pembro, or TH plus pembro for 4 cycles in the neoadjuvant setting. And their primary endpoint was pathologic complete response. Overall, the arms were pretty well balanced with similar age, similar tumor size, mostly small tumors, T1, T2 in all 3 arms. And most of these were node negative, and most of these were hormone positive as well. And what they saw was that the addition of pembrolizumab to THP, so that's the blue bar, did increase PCR rates significantly. So 67.2% with the addition of immunotherapy to THP compared to just 48.3% with THP alone. And as expected, TH with pembro had the lowest PCR rates. However, there was significant toxicity with the addition of pembro to THP, with 5% having grade 3 to 5 adverse events, and overall any grade was 18% in the THP plus pembro arm. So, and of course, it was what we expect with immunotherapy, with high rates of rash, ALT increase, hypothyroidism, and there were some cases of pneumonitis as well. So unfortunately, this seemed to be a poorly tolerated regimen, but it did increase PCR rates. So we have to think about how to safely incorporate immunotherapy into these HER2 positive neoadjuvant regimens. Margot was a randomized phase two trial comparing neoadjuvant TMP versus THP, and this was stage 2 to 3 HER2 positive breast cancer. And it randomized neoadjuvant TMP for 12 weeks versus THP. Unfortunately, although there was a trend towards an increase in PCR rates, it was not statistically significantly different with TMP versus THP. Train 3 was a very interesting study design looking at how we can incorporate radiologic complete response into tailoring how many cycles of chemotherapy patients should receive. And so this trial looked at stage 2 to 3 HER2 positive breast cancer. They received 3 cycles of TCHP, so paclitaxel, carboplatin, trastuzumab, pertuzumab. And then after 3 cycles, they had a response evaluation. And what they were looking for what they considered a radiologic complete response was complete remission on breast MRI and axillary ultrasound, as well as a negative FNA or core biopsy. And so if that was negative, then they were predicted to have a complete response and they could go ahead and go to surgery. If not, then they received an additional 3 cycles of TCHP and had a repeat response evaluation. And what this trial showed was that there was a pretty significant percentage, 34%, of patients who did have a pathologic complete response after just 3 cycles of TCHP, and that the MRI accuracy to predict the PCR was very good in the hormone negative arm, so it was 87%, and a little bit less in the hormone positive arm of about 53%. And this is showing the breakdown of most of these were T2 to T3 tumors, so on the larger side, and a little bit more than half of them were lymph node positive. And the orange arm that's up here is showing for the patients that did receive 1 to 3 cycles, 96% of them had a 3-year event-free survival. So that's very good after just 3 cycles of chemotherapy. And you can see the rates here for the 4 to 6 cycles as well. So just very interesting idea of how we can try to tailor the number of cycles of chemotherapy that we give to patients. This was another interesting trial out of Europe that looked at specifically postmenopausal women with hormone positive, HER2 positive breast cancer, tumors greater than 1 centimeter, a lymph node status either negative or 1. And they were randomized to paclitaxel and HP, so our typical THP regimen, versus palbociclib plus letrozole plus HP, so no chemotherapy, for 16 weeks prior to surgery. And overall, the 2 arms were pretty well balanced. The median age was 69. As you can see, most of these tumors were about 2.5 centimeters. And most of these were lymph node negative. And of course, they were all hormone positive. And what it showed was that overall, the palbociclib, letrozole, and HP arm was much better tolerated. So early discontinuation due to adverse events, only 2.8% in that arm compared to the chemotherapy arm. And a much higher percentage of patients completed all 4 cycles of treatment in the neoadjuvant setting. Overall, the PCR rates were low, as we would expect, but equivalent in the 2 arms. So very interesting to think about that without chemotherapy, these patients with palbociclib and letrozole and HP were able to achieve an equivalent PCR rate. So moving on, ZEST was a trial looking at stage 1 to 3 breast cancers with residual disease who were being monitored with ctDNA. So this was one of the first few trials presenting ctDNA-guided early intervention. And so patients were monitored with ctDNA surveillance. If they were ctDNA positive, they were imaged, and if they did not have any metastatic disease, they then went on to receive either niraparib or placebo. And they had a BRCA mutated group as well as a BRCA wild type group. Unfortunately, this trial was stopped early because they had very slow accrual. It was unfortunately during it was affected by COVID, as well as a very high percentage of patients being metastatic at the time of ctDNA positivity, so they weren't eligible to go on the trial. And they were also seeing a very low positivity rate in general when they were screening these patients. So unfortunately, it was stopped early. But what they presented here at the San Antonio conference was that there did seem to be at least a numeric trend towards benefit with niraparib versus placebo. But of course, we can't make any statistically significant conclusions because the trial was terminated early. So I think this is important because it's one of the early trials looking at intervention based on ctDNA positivity, and it suggests that most likely this could be successful, but we have to think about how we can design these trials to make sure that we're able to accrue the number of patients that we need, and how to design these trials thoughtfully so that they're successful. And we learned a lot about ctDNA positivity rates from this trial, as well as the fact that a lot of these patients with residual triple-negative breast cancer turn ctDNA positive very early on after surgery, and that a lot of them are unfortunately metastatic. And so we learned a lot about ctDNA positivity in this cohort. There was also an update from Olympia at San Antonio, and this, just as a reminder, is looking at patients with BRCA1 or 2 mutations, stage 2 to 3 breast cancer, triple negative as well as hormone positive, who were randomized to olaparib adjuvantly versus placebo. And what they showed was that there is statistically significant improvement in invasive disease-free survival, and that at the 6-year follow-up, the curves continue to separate with a significant difference of 9.4% improvement with olaparib compared to placebo. So very reassuring data. And then the Be Well trial was also very interesting, looking at stage 2 to 3 breast cancer. And this was looking at hormone positive or triple negative breast cancer who were diagnosed within the past 14 months, and they had completed their surgery and/or chemotherapy or radiation that was indicated, who had a BMI of greater than or equal to 27. And they were randomized to health education plus 2 years of telephone-based weight loss intervention versus health education alone. And their primary objective is invasive disease-free survival. So we're still waiting eagerly for the invasive disease-free survival, but what they did present at the conference was some of the metabolic and inflammatory biomarkers that they looked at. And what it showed was that, for example, leptin, they saw a decrease in the intervention arm. So patients who were receiving that extra support for weight loss had lower levels of leptin, lower levels of insulin, as well as lower levels of insulin resistance. So very promising and interesting biomarker is that these patients are most likely benefiting from this extra intervention for weight loss. So in conclusion, we certainly need more data regarding how to safely and effectively incorporate immunotherapy and antibody drug conjugates in the neoadjuvant space, but really some promising data that was presented that suggests that we can perhaps start to think about how we can start to get rid of our old chemotherapies and start to incorporate some of these newer, more targeted treatments in the neoadjuvant setting. We need more biomarker analysis to try to figure out who are these subsets of patients who might benefit more from the addition of immunotherapy, as well as more imaging biomarker data as well, and think about how we can start to tailor the number of cycles and not just the regimen that we're doing for patients. And I just wanted to thank all the patients who participate in our clinical trials and their support system that helped to move the field forward. Thank you so much.
Thank you so much, Dr. Rozenblit. And to the audience, you're welcome to put in any questions or comments in Q&A. But while we're waiting, I do see a question, so we'll definitely come to that. But just kind of coming back to the Taylor RX analysis that you presented, you mentioned it briefly, but if you could just elaborate a little bit more in terms of how you are thinking about anthracycline use in hormone receptor positive breast cancer, taking into account that as we all know, 2024 also saw the updated analysis from the ABC studies, kind of again comparing anthracycline-based regimen versus not. So we'd love to hear more of your thoughts on that.
Yeah, I think that's a great question. I think the problem with TAILORx, as we know, is that very few of these patients received ovarian suppression. So we still don't quite have the answer of whether it's truly the chemotherapy versus the actual ovarian suppression that's benefiting these younger women. And I think that the tendency is we worry more about the younger women who are premenopausal, who do have these larger tumors. But we also know that anthracyclines, of course, carry the risk of cardiotoxicity and potential low risk of leukemia, but that's something that we worry about. So this is a very interesting analysis. I don't think it's changed my management quite yet. I think we need more data. And I think future trials that are comparing chemotherapy versus ovarian suppression will help us answer that question in the future.
Very important points, and continuing to taking into account the toxicity risk as well as the disease biology, I think is an important takeaway from this analysis as well. Returning to the question on the chat is an important question on patients who have germline BRCA alterations, who likely are being treated in the Keynote 522 regimen and are then in that adjuvant pembro portion. The question is about the addition of olaparib in this patient population.
Yeah, so this is unfortunately still an evidence-free space that we want to have the answer to. And so I think that most of us are combining the PARP inhibitors with the immunotherapy, and we think that it's safe, but we certainly need more data to evaluate that further.
Certainly, because we, as we all know, that we have the survival advantage seen in the Olympia study. I think it's important for this patient population to still derive that benefit, even though that was not how the Keynote 522 study was designed. So yes, as my colleague mentioned, we are combining the two based on prior studies that have shown safety of combination with PARP inhibitor and immunotherapy. So I think if your patient has a germline alteration, I think it's important to prioritize the olaparib over capecitabine. Dr. Rozenblit, I know you're doing a lot of pioneering work in ctDNA in the adjuvant setting. I want to kind of return to kind of the questions that we're continuing to get from our patients in clinic. They come to us wanting these tests done as part of surveillance models. So I guess my question is two parts in terms of where do you think we are in terms of the evidence of using this type of testing in routine practice? And number two, if you could highlight some of the upcoming studies that are looking at ctDNA as predictive biomarkers.
Sure. So ctDNA is very interesting. So for those of you who have not heard of this, it's circulating tumor cells that are released into the blood. And there are several assays currently out there that are commercially approved and are available. One of them is Natera, another one is Guardant, and so they are beginning to be advertised. And so what we know so far is that these assays are very sensitive and very specific. So they seem to be very good at picking up the ctDNA, and when the ctDNA is positive, it's very highly predictive of a metastatic recurrence. And the sensitivity seems to be very high in the high 90s in terms of percentage for predicting a recurrence. So far from the studies that we have, we think the lead time, so the time between a test turning positive and seeing something on imaging is several months. So what we learned from ZEST, which looked at the triple negative group, is that if there's a very large tumor to begin with, or a lot of residual disease left after neoadjuvant treatment, if those patients are ctDNA positive, then unfortunately the time to metastatic recurrence is probably short. And when they were imaged on the trial, they were either metastatic at that time already or became metastatic in 2 to 3 months. In the hormone positive group, it's a little bit different. And we are seeing in general much lower ctDNA positivity rates. From trials like DARE and Monarchy that have come out, we think that even patients with larger hormone positive tumors that are lymph node positive, the ctDNA positivity rate is probably 10% or less. And there's probably a longer lead time. So far, we're seeing on average 12 months between ctDNA positivity and a metastatic recurrence. So a lot of trials right now are looking at what can we do in this lead time. So when the test is positive and there's still no metastatic lesions on imaging, how can we treat these patients to prevent a recurrence? And so that's where the field is right now. And there are a lot of trials coming out that are going to be looking at this, but we don't have the answer yet. And so our recommendation has been to not do the commercial ctDNA testing yet because it may cause anxiety for patients, and we don't quite know what to do with those results yet. And we don't know if any treatment is going to be efficacious in the setting. And so we have to wait a little bit more for the data to come out before we start to incorporate this testing in our clinical practice.
And if you don't mind commenting on some of the trials that you see promising in this area.
Yes. So one of the trials that I'm working on along with Dr. Lusberg is there's going to be a trial that we designed coming out through the TBCRC, looking at using elacestrant, so one of the novel selective estrogen receptor degraders. And when patients turn ctDNA positive, treating them with elacestrant to see if the ctDNA turns from being positive to negative. As well as whether it reduces the risk of these patients developing a metastatic recurrence in the future. There are also currently ongoing trials. So we mentioned DARE. This is a trial that was designed by Dr. Pushtai that's open across several centers in the country. That's also looking at patients with hormone positive breast cancer. And if they turn ctDNA positive, randomizing them to either continuing standard adjuvant endocrine therapy versus adding fulvestrant and a CDK4/6 inhibitor to see if that clears the ctDNA and decreases the risk of metastatic recurrence. There are also several trials in the triple negative space as well. I don't know if you want to add, Dr. Lisberg, I'm on the other trials as well.
Yeah, no. So I think the most important takeaway, as you mentioned, is that I think having good shared decision making with patients and trying to direct them to these interventional studies is really our highest recommendation. There are several studies focusing on kind of the patients with triple negative breast cancer with residual disease, but as my colleague mentioned, the time window to intervene for this patient population is even narrower. So I think several of the studies have had a challenge, but the idea would be if we can identify a certain molecular pattern within the ctDNA that can let us better target this adjuvant intervention space for this high-risk population. I think
I-
that's where a lot of the trials are headed.
And I think,
Um,
sorry, and I think one of the challenges also is that we want to intervene, but we also want to intervene with something that is not too toxic because it's still a blood test, it's still a biomarker, they're not metastatic yet. And so we have to find some balance between having an efficacious intervention, but also something that is not too toxic because we also don't want to overtreat.
yes, yes. So I think this is going to be a rapidly evolving space. So I think every year we'll have kind of additional information to help guide our patients. I don't see other questions in the Q&A, but I will kind of wrap up with one additional question, even though this was not a topic. It was presented in ESMO and ASCO of last year. I do want to kind of take a moment for Dr. Rozenblit to highlight the two adjuvant CDK4/6 inhibitors that now we have approval for in early stage high-risk breast cancer. And I think we had some greater maturity of data with ribociclib that was presented in ASCO 24 as well as ESMO 24. So if you could take a moment to just comment on kind of the two approved CDK4/6 inhibitors and how you choose between them in your practice.
Yes, absolutely. So we now have abemaciclib and ribociclib approved in the adjuvant setting. The data with abemaciclib came out a little bit earlier, so that was approved earlier. And that is approved for tumors that are on the larger side, so at least T2 or lymph node positive. And so we had very specific criteria for when patients were eligible for the abemaciclib. The trial for looking at adjuvant ribociclib included lymph node negative tumors as well. And so now we have ribociclib approved in this setting, and now we have patients that are eligible for adjuvant ribociclib, even if they're lymph node negative. But we do think about some other high-risk features, so those tumors should at least be grade 3, on the larger side, so at least T2, that increases their risk of recurrence to think about giving an adjuvant treatment. So in general, when I think about which one to choose, it's nice to have a choice now that we have two that are approved. The time is a little bit different as well because of the way that the trials were designed. So the ribociclib is approved for 3 years, the abemaciclib is approved for 2 years. So that's something to take into consideration. And the side effect profile is a little bit different. So abemaciclib tends to cause more diarrhea in patients. Ribociclib tends to cause less diarrhea, but more fatigue. So the main consideration for me is how big is the tumor? Are there lymph nodes involved? If there are more lymph nodes and it's a larger tumor, I tend to sway more towards abemaciclib just because of the way that trial was designed. But theoretically, they should be equivalent. We don't have any data to suggest that one is superior to another. They're most likely equivalent. And of course, the other big consideration that I take into account is the other comorbidities and the other things that the patient may be struggling with. So my patients who are more constipated at baseline tend to do very well with abemaciclib. If somebody has a cardiac risk factors that are underlying, I worry about that a little bit more with ribociclib. There is a very low risk of QTc prolongation with ribociclib. So you also have to think about what other medications are they on? Are there going to be medication interactions? Is there something in their medical history that makes you worry a little bit more about the QTc? But for me, the main thing that usually drives it is the side effect profile, and I'll often present both options to patients and see which one they prefer.
Great. We have a couple of more questions on the chat. I'm going to go backwards to just kind of keep on topic with the CDK4/6 inhibitor. So this is the second question right now that's active on the chat. And it's a great question about do we do more axillary surgery, more local regional assessment to make patients quote unquote eligible for these CDK4/6 inhibitors? So this is a hot topic. So thank you for that question, Dr. Rozenblit.
That's a great question and something that gets brought up at our tumor board all the time, where our surgeons are very thoughtful, and before they think about kind of omitting axillary surgery, it's certainly something that they bring up and we discuss as a group whether it would change our medical management. I think in general, for most patients, we we try to do the axillary management in terms of what is the most appropriate from the surgical standpoint. And we can always kind of think about the CDK6 inhibitor in the adjuvant setting regardless. So even if somebody doesn't quite, meet the official criteria, but you're worried about their lymph node status, I think that you could still think about giving it to them. And especially now with ribociclib approved for lymph node negative tumors as well, I think it's a little bit less of an issue where you don't have to quite meet that criteria of a specific number of lymph nodes. And so patients could still be eligible for an adjuvant CDK4/6 inhibitor, even if they didn't perhaps have quite the number of lymph nodes that we needed initially when these medications were approved.
Yeah, I think it's a great question. And there's even a second question along those same lines, which is that, what we don't want to do is to be causing more local regional morbidity. Even a sentinel node evaluation can be associated with a risk of lymphedema. So these are, I think, looking at the biology of the tumor and not simply doing surgery to make someone eligible, but really using your other biomarkers, looking at your Ki-67, the grade of the tumor, the oncotype, all of those things can kind of help you decide on the adjuvant CDK4/6 inhibitor. And since we do have now an indication to use ribociclib for node negative disease, that also kind of maybe simplifies the decision, whereas before, when we only had a BEMA, that was not as possible. So you're going to see this question debated in multiple tumor boards. So we're not saying that it's never done, but really in general, I think breast cancer, as you all know, is a systemic disease. And so optimizing systemic therapies and getting away from kind of causing morbidity using local regional aggressive care is really where the field is going. And in many of these studies, kind of similar management strategies with the axilla were employed. So our strongest recommendation is not to simply go digging into the axilla to make someone eligible. And then, so kind of similar questions about who is eligible for these CDK4/6 inhibitors. So you don't absolutely need that nodal status. You need those biological characteristics to determine whether they fit the Natalie criteria. So that was one of the other questions that came up. Going to come back to the ctDNA question, there is a good question kind of trying to understand kind of the differences between the tumor-informed assays, Dr. Rozenblit, and the tumor-agnostic assays. So they were just kind of trying to understand what is actually tested, when is the tumor actually needed.
Yeah, that's a great question. So the tumor-informed assays actually take some of the tissue from the original breast tumor and analyze that tissue for several different variants. And how many variants the assay is looking at depends a little bit on that particular assay. But most of the assays are picking out several different variants that are seen in the tumor and not seen in normal DNA. And it's specific to that patient and specific to that tumor. And based on the variants that they find, they then design that assay and then test it in the blood. And so when something comes back as ctDNA positive, it means that it's finding those variants that were seen in the DNA of the initial tumor. Most of the assays out there now are using whole genome sequencing, meaning that they're looking at the whole genome. And so there's much more variants to pick from. And they're also looking at more variants when they design the assays. Tumor agnostic means that you don't need the tissue from the initial tumor and that you have a preset number of variants that have been associated with cancer in general, and you're looking for those variants in the blood. So in general, so far, the data seems to suggest that the tumor-informed assays are more sensitive meaning that because they're designed for each individual tumor, when they pick up the variants, they're much more likely to be a true positive, and they're much more likely to be predictive of a recurrence for that cancer. The tumor agnostic are very useful to think about because we don't always have tissue that's easily accessible. So we're talking about specifically for the hormone positive group, tumors that might have been diagnosed 10 or 15 years ago. Sometimes when we think about late recurrences, or even 5 years ago, and if a patient switched institutions or moved across state lines, it can be sometimes very difficult to hunt down that tissue. So ideally, I think it would be nice to have an agnostic test where we don't necessarily need that original tissue. But so far, and of course, their assays are still being developed, but so far they seem a little less sensitive. So there might be some false negatives in those assays. They might be missing some of those variants to that particular tumor because they're looking at a general panel. But when they're positive, they're still very highly predictive of a recurrence.
So, yeah, absolutely. And I think there has been kind of great interest in terms of widespread screening for various malignancies using these blood-based assays, and definitely not ready for prime time. But as my colleague mentioned, I think the technology continues to expand, and there is tremendous public interest in how nice would it be if we had a personalized blood test that could detect cancer before things got too late. So I do think this is going to continue to expand. So we really do encourage our patients to participate in these trials so that we can really give evidence-based recommendations as these data mature. I see one more questions, which is for BRCA positive patients. Can BRCA positive patients be started on tamoxifen for chemo prevention in spite of the fact that most of these cancers are TNBC?
That's a great question. So, yeah, so it's very interesting because the classic teaching is that in BRCA positive patients, they are less likely to have hormone positive breast cancers. And so we're just a little bit unsure about the benefit of chemo prevention with tamoxifen in those patients. I think it's not wrong to start somebody on that if they want to do tamoxifen for chemo prevention, but we just can't quote that 50% reduction in breast cancer like we can for other patients because with the higher percentage of triple negative and even HER2 positive breast cancers that we see, it's probably just a lower risk reduction than we would like. So it depends a little bit on the side effect profile and really what the patient prefers. But I don't think it's wrong to do it.
Great. And maybe before we complete the night, if you could comment on TAMLO, low dose tamoxifen versus full dose tamoxifen in chemo prevention.
Yeah, so TAMO1 is a trial that came out of Europe a couple of years ago now, and we were all very excited to see that 5 milligrams of tamoxifen was just as effective as full dose tamoxifen. And the population that they specifically looked at were patients with DCIS and atypical ductal hyperplasia and LCIS. So these are patients who are at an increased risk for breast cancer, but don't have invasive disease yet. And they compared the full dose to the 5 milligrams, and they saw the same risk reduction of about that 50 to 55% risk reduction. And the side effect profile was much better in the 5 milligram tamoxifen group. So fewer hot flashes, much lower risk of blood clots and endometrial cancer that we always worry about with tamoxifen. So very exciting, and it's become a really nice option, especially for our postmenopausal women where aromatase inhibitors have a lot of side effects, especially arthralgias that we worry about. And so 5 milligrams of tamoxifen can often be much better tolerated. Looking back at that trial, there wasn't specifically data looking at premenopausal women, so it's a little bit more unclear whether it's as effective in our premenopausal women. But certainly something to think about when someone can't tolerate the full 20 milligrams, that the 5 milligrams is an option.
Completely agree. And Alliance just launched a low-dose tamoxifen trial in low-risk invasive breast cancer. So I think the low-TAM study will be launching soon in many places throughout the country. So that's going to be an additional option as we think about the dosing of tamoxifen even in invasive breast cancer. So yes. So thank you for this great audience and your wonderful questions. Special thanks to our wonderful presenter, Dr. Mariya Rozenblit, and hope you all join us next week for metastatic breast cancer update by Dr. Adriana Khan. Thank you so much. Have a great night.
Thank you.